Bismillahirrahmanirrahim. This is the last chapter in the ABG interpretation. We are going to talk about the respiratory problem, whether respiratory acidosis or respiratory alkalosis, whether primary or secondary, and then metabolic problems, metabolic acidosis with its different types, metabolic alkalosis, either also primary or secondary. And after that, we are going to talk or to study some of these problems separately. I think how to study the ABG. To start with, it's better. First, you have to take a good history and listen to the clinical status of the patient. Before you start looking at the ABG chart, first know what's the clinical problems, the history, the sequelae of events. This is very important because in order to have an idea about the expected metabolic derangement. And after that, look at the lab investigations. Lab investigation you should look at it. And at the same time, you should register it, write it down in this monograph. And after that, look at the ABG. So the ABG, don't look at the ABG first. You have to listen to the clinical, and then the lab investigations, and after that, look at the chart. Well, after that, you have to build this monograph. It is very important to fill this monograph because you are going to fill these data and then calculate the monitors. These are the monitors to be calculated, corrected bicarbonate, or the previous set of bicarbonate if the patient is having some sort of mixed problems. So in this case, you can know the previous set of bicarbonate. When you study the chloride sodium ratio, is it hemoconcentration, hemodilutions, or addition of sodium, or addition of chloride, or loss of chloride, or loss of sodium, something like that. This will give you a clue to the pathology of this electrolytes. And at the same time, when you look at the anion gaps, see the anion gaps is high, or normal, or low, something like that. This will help you interpret the type of reaction which has happened. Corrected anion gap if there's some sort of problem with the albumin itself. You have to know the correct anion or the anion gap for this patient if the patient is having some abnormality with albumin or phosphate. Strong iron differences, this is another important clue for the diagnosis. This is a metabolic problem. And this is a change of sodium, change of chloride, and so you can define is it alkalosis or acidosis. Buffer base, this is another problem which will help you define what is the metabolic problem of these patients, whether this is alkalosis or acidosis. And the strong ion gap, this is what about the addition uh, of these fixed or non-fixed acids to the circulation. So, and the same thing for like the basic cells of base deficit. So, from this chart, you'll see that the patient is having some problem with the carbon dioxide hypo or hyper, and this is associated with hypoxia or not. If the patient is having hypoxia, this is hypoxia due to hypercarbia or hypercarbonate. This is carbon dioxide high, and this is hypoxia, or high carbon dioxide with normal alveolar arterial gradients, no hypoxia. This is another, from this study, you are going to see what's wrong. Look at this is first respiratory. Respiratory problems is maybe respiratory acidosis or respiratory alkalosis. In this talk, we are going to talk about respiratory acidosis. Respiratory acidosis, we have mentioned before, this is carbon dioxide, increase in the carbon dioxide. And this carbon dioxide may be retained when you look at this formula. Carbon partial pressure of carbon dioxide equals carbon dioxide output multiplied by the barometric pressure minus water vapor over the alveolar minute volume, which is the tidal volume minus the dead space multiplied by the respiratory rate. Carbon dioxide increase. This may be due to increase in the carbon dioxide output. And this is the commonest one is the case of liver steatosis, as we have mentioned before, where in patients who is taking a high amount of glucose, more than 7.5 milligram per kilogram per minute, as in case of TB and total brain nutrition. In this case, there is some sort of what we call liver steatosis. Carbon dioxide and the bicarbonate will be transformed into levels. The transformations of carbohydrates into levels, the spatial quotient is 8, not 0.8, it is 8. This means that consumption of one uh, 1 mole of oxygen will be associated with productions of 8 moles of carbon dioxide. This is the commonest one. The commonest one in the case of carbon dioxide output. Another important point, which is this is a commonest here, which is the decrease in the alveolar volume. Decrease in the alveolar volume means the decrease in the total volume. Decrease in total volume as in the case of chest infection, pneumonia, or aspiration, or in the case of pneumothorax, or in the case of heart failure, or in the case of bronchial asthma. All this is to decrease in the total volume. This is in the case of pulmonary embolism, respiratory decrease due to an pathology which leads to a decrease in the respiratory rate. So this should be considered while you are talking about the high carbon dioxide or retention of carbon dioxide. These are the commonest causes, maybe in the brainstem, as in brainstem injury, hemorrhage, or metabolic encephalopathy, or depression, drugs, spinal cord like trauma, tumor, transverse myelitis, nerves like neuropathy, Guillain-Barré, or motor neuron disease. In the cases of neuromuscular junctions problem like myasthenia gravis, neuromuscular blockers, or respiratory muscle myopathy, nutrition dystrophy, or fatigue, respiratory system itself, this is upper way obstructions or decreased lung, pleural, or chest wall compliance. Look at this. This is an example. We're going to study it. This is a patient with COPD patient. He's stable and came for just say for checkup or assessment in your outpatient clinic. This is a patient of 40 years age, and his pH is 7.34, carbon dioxide is 60, oxygen 53, bicarbonate 31, chloride 97, sodium on 40, potassium 4, and he's on room air. Look at when you bought this data on this monograph, the pH here is 7.3, close to the normal, but this patient is stable. When you look at the carbon dioxide is 60. Carbon dioxide is 60. This means that the patient is having retention of carbon dioxide. You can look at down here. The patient is on room air. Alveolar oxygen, when you measure it, this means that the FiO2 multiplied by barometric pressure 700. This means 147 minus carbon dioxide over respiratory quotient 7.8. The alveolar oxygen in this case would be about 65 millimeter mercury. This is alveolar oxygen. So when you look at the oxygens, the arterial oxygen of this patient is written here 53. So the difference between the two is 12. This 12 is alveolar gradient is normal because for this age, the the alveolar gradient for this age is 20, which is room air. 20 multiplied by the age plus 2.5. This means about 12. This is the same. So this patient is hypoxic. This is oxygen. The patient is hypoxic, but this hypoxia is due to carbon dioxide retentions. So this is hypoxia due to hypoventilation or the increase in carbon dioxide. Back again, when it comes to the bicarbonate, here the bicarbonate, this is carbon dioxide retention. This is respiratory acidosis. But this compensation is here by the bicarbonate. When you come to the to study it, this is normal. This is a chronic state. Retention of 1 millimeter mercury of carbon dioxide will be associated with the retention of bicarbonate 0.35. Here retention is 20 millimeter mercury. 20 by multiplied by 0.35. This gives you 7. 7 plus 24. This is 31. So this is a metabolic alkalosis due to increase in bicarbonate, but it is compensation for the retention of carbon dioxide for sure. When you come to the corrected bicarbonate, this means that the measured bicarbonate plus the actual anion gap minus 12. What's the anion gap here? This is the sodium, this is the chloride, and this is the bicarbonate. The anion gap here, when you measure it, it is about here 12. It's normal anion gap. So the anion gap will be the same like actual anion gap. So this is the actual problem. So there is no mixed problem. Come to the sodium is called normal, potassium normal. But look at here, this is the chloride is low. The chloride is low because this is patient is having a partial pressure of carbon dioxide is high, stimulates the carbonic anhydrase to form bicarbonate. So the retention of bicarbonate will be concomitant loss of chloride. This is an electron neutrality. That's why when you add the bicarbonate plus the chloride, the two together will be about 130. This is the normal anion gap. So this is an look at how can you know this? This is chloride divided by certain ratio to the sodium. Chloride to sodium ratio is less than 75% due to the decrease in the chloride. Decrease in the chloride with concomitant increase in the bicarbonate. So this patient is having a hypochloremic metabolic alkalosis as compensatory. You can catch this. This is a strong iron difference. Strong iron difference is more than 40. This is alkalosis. This is a hypochloremic due to decrease in the chloride. Hypochloremic metabolic alkalosis, but this is a compensatory due to respiratory acidosis. Buffer bases increase for sure due to the increase in the bicarbonate. So this is another clue. This is a metabolic alkalosis due to this is a compensatory due to respiratory acidosis. Strong iron difference is decreased due to the retention of carbon dioxide. So from this study, I think from when we studied this chart by this way, we came to the conclusion that this is stable COPD with chronic respiratory acidosis, so with compensatory metabolic alkalosis, and the patient is close to the normal, and this patient is stable. For sure, and the patient is hypoxic was due to carbon dioxide retentions, and this is the case. This is the uh, this how to start the case. We are going to complete these studies again. And thank you.